Welcome to the Explainer. Today, we're stepping right onto a microscopic construction site. When we talk about bone and mineral metabolism, we aren't just looking at some static, dusty skeleton. No, we're looking at a highly dynamic, endlessly remodeling structure. It requires specialized crews, vital materials, complex supply chains, and a hidden electrical grid to keep the whole operation running smoothly. If you're looking for a high-yield physiological masterclass that pieces together exactly how our bodies balance these crucial elements, well, you are in the exact right place. Let's get to work.
Okay, let's dive into this outline. We'll build our understanding from the ground up, starting with Section 1, the bone construction crew. Then we'll cover Section 2, calcium, our structural foundation. Section 3 is phosphate, the vital mortar. Section 4 covers vitamin D, the supply chain manager. And finally, Section 5, magnesium, the hidden power.
All right, starting off with Section 1, the bone construction crew. Meet the builders and demolishers.
On any good construction site, you've got to have builders and you've got to have demolishers. Enter our builders, the osteoblasts. These guys have mesenchymal origins, and their entire job is to synthesize that organic matrix and regulate mineralization. Pretty straightforward, right? But then we have our demolishers, the osteoclasts. Surprisingly, these come from a totally different lineage. They're hemopoietic, originating from macrophage precursors. They literally merge together to form massive multinucleated cells that actively resorb bone. How do they do it? Well, they pump out hydrochloric acid to dissolve the minerals, and they use cathepsin K to just chew right through the organic matrix. But here is the really cool part. They do not work in isolation. The osteoblasts actually regulate the demolishers. By expressing a signal called rank ligand, our builders effectively tell the demolishers exactly when and where to start breaking things down. So who's actually managing both of these teams? That would be the osteocytes. And get this, they are actually the most numerous bone cells we have. Think of them as the long-lived site sensors, embedded deep within the bone matrix itself. They act as this vast mechanosensory network. Whenever they sense mechanical loads or even a lack of load, they send out chemical memos to the osteoblasts. For instance, they secrete sclerostin, which basically acts as a hard brake on the osteoblasts, stopping new bone formation. They also secrete a massive player we'll be talking a lot about today, FGF23, which is the absolute primary manager of our body's phosphate levels.
Moving right along to Section 2, calcium, the structural foundation, managing the materials.
Now, while more than 99% of the body's calcium is safely locked away in the skeleton, clinical medicine is absolutely obsessed with a tiny, freely exchangeable fraction floating around in the blood. And this brilliantly illustrates why. Let's break it down. We have a total serum calcium of roughly 8.5 to 10.5 milligrams per deciliter. But 40% of that is bound up by proteins like albumin, and another 10% is complex to things like phosphate and citrate. That leaves exactly 50% as ionized calcium. This is the free, biologically active form. When your patient is acutely ill, this ionized fraction is the exact number that determines if their nerves and muscles are actually going to fire properly. Because this balance is so precarious, it's heavily tested and incredibly relevant at the bedside. Let's hit a few vital pearls here. First up, acidosis increases active ionized calcium. Why? Because all those excess hydrogen ions basically bump calcium right off the albumin, freeing it up into the blood. Second, if your patient has low albumin, their total calcium is going to look falsely low. You have to correct for this. The rule of thumb, add 0.8 milligrams per deciliter to the total calcium for every 1 gram per deciliter drop in albumin below normal. Oh, and finally, you've got to know your diuretics. Thiazide diuretics decrease urinary calcium. They hold on to it. Loop diuretics, on the other hand, increase urinary calcium loss. Huge difference there. Let's jump into Section 3, phosphate, the vital mortar, the daily flux. Phosphate levels are wild. They're highly dynamic, naturally swinging by up to 50% throughout a single day. But there is a threshold where this normal daily flux turns into a full-blown clinical emergency. That number is less than 0.25 millimoles per liter. This is the deadly drop zone. Below this level, your body literally runs out of the raw materials needed to make ATP. No energy means severe neuromuscular weakness, seizures, respiratory failure, coma, and profound rhabdomyolysis. It's a true metabolic crisis, for sure.
Let's see how this builds into an overall clinical picture. What actually causes such severe hypophosphatemia? A lot of the time, it's a massive shift of phosphate straight into the cells. A classic example is treating diabetic ketoacidosis. When you start insulin therapy, that insulin drives glucose and phosphate right along with it into the cells, causing blood levels to absolutely plummet a few hours later. You treat this by meticulously replacing phosphate, either IV or orally. On the flip side, hyperphosphatemia almost always happens when the kidneys fail, like in chronic kidney disease, or when a huge amount of intracellular phosphate is suddenly dumped into the blood, like we see in tumor lysis syndrome. You manage that overload by expanding volume to flush it out, using gut binders, or stepping in with hemodialysis.
Up next is Section 4, Vitamin D, Supply Chain Manager, Sourcing to Inactivation.
Now, vitamin D doesn't just magically appear in its active form. It goes on a 4-step metabolic journey. Step 1 is synthesis, right in the skin, where UV radiation creates vitamin D3. Step 2 takes us to the liver, which adds a hydroxyl group to create 25-OH vitamin D. Think of this as your major circulating storage form. Step 3 is the tightly regulated, absolutely crucial step. Here, the kidney uses an enzyme called 1-alpha hydroxylase to create the active powerhouse hormone, 1,25-dihydroxyvitamin D. This is the form that actually tells your gut to start absorbing calcium and phosphate. Finally, step 4 is inactivation via 24-hydroxylase, just so the system doesn't overwork itself. Fascinatingly, rogue macrophages in granulomatous diseases, think sarcoidosis, can actually produce their own 1-alpha hydroxylase. That leads to dangerous, completely unregulated spikes in active vitamin D and severe hypercalcemia.
So the crucial point here is how we actually measure for deficiency. You might be thinking, hey, I'll just measure the active form to see if the patient has enough. But hold on, there is a massive paradox here. In vitamin D deficiency, the active 125 form can actually be completely normal or even elevated. Wait, no way, right? Why does that happen? Because as your calcium drops, the parathyroid gland panics. It spikes the release of PTH. That high PTH whips the kidney into an absolute frenzy, maximizing 1-alpha hydroxylase activity to aggressively convert whatever storage vitamin D is left into the active form. Therefore, to know what's really sitting in the warehouse, you must always measure the storage form, 25-OH vitamin D.
When that supply chain totally fails, the clinical presentation depends entirely on the age of the patient. In children, before the growth plates have fused, a lack of vitamin D causes rickets. The cartilage keeps trying to grow, but just cannot mineralize. This results in widened, distorted growth plates, bowing of the legs, and those characteristic bumps along the ribs we call a rachitic rosary. Now in adults, because the growth plates are already fused, the exact same deficiency causes osteomalacia. Instead of bone distortion, adults get impaired mineralization of their existing bone matrix. This leads to excruciating bone pain, profound proximal muscle weakness, and pseudofractures, which are those striking radiolucent lines you'll see on an X-ray, often called Lucer zones.
Beyond just nutritional deficiency, we have to look at genetic disruptions to this pathway. Look at the stark difference between vitamin D-dependent rickets type 1 and type 2. Type 1 is a failure to actually produce the active hormone because that kidney enzyme is mutated, so active vitamin D is low. Type 2, however, is a mutation in the receptor itself. The hormone is floating right there, but the body just can't hear it. So in type 2, active vitamin D levels are absolutely through the roof. And here's an incredible clinical feature you have to know. Patients with type 2 have total alopecia. Why? Because the vitamin D receptor is strictly required for normal hair follicle regeneration. Amazing, right? Finally, keep tumor-induced osteomalacia on your radar. This is where hidden mesenchymal tumors secrete massive amounts of FGF23, which dumps all your phosphate into the urine and blocks active vitamin D production entirely.
All right, our final stop, Section 5, Magnesium, the hidden power, the electrical grid.
Magnesium really operates in the background, but let me tell you, its extremes are devastating. Hypomagnesemia is incredibly common. We see it all the time, driven by chronic alcohol use, loop diuretics, or gut malabsorption. The neuromuscular effects here are rapidly excitatory. We're talking tetany, tremors, and even seizures. Hypermagnesemia, conversely, is exceedingly rare in people with normal, healthy kidneys. It almost always occurs in the setting of renal failure paired with excessive external intake, like someone taking massive doses of magnesium-based laxatives. Its effects are deeply depressive, slowly causing a neuromuscular blockade that results in a loss of reflexes, paralysis, and eventually coma.
Now, what's really interesting about this slide is this fascinating physiological hostage situation. Severe hypomagnesemia actually causes hypocalcemia. But here is the real kicker. That low calcium is totally refractory to calcium replacement. You can pump your patient full of IV calcium and their levels will not budge one bit. Why? Because the parathyroid gland strictly requires magnesium to secrete PTH.
Without magnesium, PTH production drops to zero, and the target organs become completely resistant to whatever tiny bit of PTH might be left. You absolutely must fix the power grid. You have to replete the magnesium before that calcium will ever normalize.
Taking this directly to the bedside, here are 2 high-stakes clinical applications you'll see all the time. First, long-term use of proton pump inhibitors, or PPIs, can cause profound, unexplained hypomagnesemia through a mysterious gut mechanism. If you see persistently low magnesium in these patients, you must stop the PPI. Second, when you're deliberately giving high doses of IV magnesium, say when treating severe preeclampsia, you have to monitor for toxicity. The very first thing to disappear as magnesium levels rise above 4 millimoles per liter are the deep tendon reflexes. Checking those reflexes at the bedside is your real-time, built-in clinical monitor to prevent catastrophic respiratory failure and cardiac arrest.
So, as you can see, bone metabolism isn't just some static anatomy lesson. It's a brilliant, highly interconnected physiological web. So, I'll leave you with this thought. Now that you can clearly see the hidden supply chains and electrical grids running just beneath the surface, how will this blueprint change your approach the next time you face a complex metabolic crisis? Keep connecting those dots, and we'll catch you on the next explainer.